All right, so part of what we've been going over is chest X-ray examination, or kind of what we need to know, kind of as respiratory therapists. So we've got a series of X-rays that we'll look at here, and I'll try to point out some different things, terms in which we want to make sure that we understand radiopaque and radiolucent. So if something shows up more radiopaque, it's going to have a shade of gray or shade of white to it. So your bone, fluid, fat, anything of that nature would show up more of a radiopaque color, as opposed to where your air-filled spaces, those will show up more of your radiolucent. So radiopaque shows up more dark, radiolucent shows up more dark, while radiopaque shows up a various shade of gray or white, if you will. When you're looking at the chest X-ray, you want to make sure that the patient's properly oriented. So we want to make sure also that we look at the clavicles so you can see, and I think I've got the color red here, so I'm going to kind of put a little bit of a line over where these clavicles are at. Those clavicles should be pretty well straight across. You can see that these clavicles, although they're not terribly uneven, they are uneven, which is going to indicate a little bit of rotation for your patient. On a decently exposed chest X-ray film, you should be able to see the spinous processing throughout the cervical and thoracic vertebrae down. You should also be able to make out a good cardiac silhouette. Now, there's some pathology going on in this chest X-ray, so we'll look at it again. We also want to make sure that we can orient the film that it's right side up. There usually should be a tag of some sort to indicate that we're looking at the right or the left side of the patient. So when you're looking at a chest X-ray, the patient's right is actually going to be on your left. If you're looking at it head on, the patient's left would be on your right. So I'll put a L tag for left over here, which will be, you're looking at the screen on the right hand side, and I've placed an R tag over here for right, which would be on your left if you're looking at the screen. So obviously you want to make sure that you can see the entire chest on the image. You'll notice the dome-shaped muscle right here. Try to trace that if I can. That's your diaphragm. Where the rib meets the diaphragm, where the ribs meet the diaphragm, there's an angle that gets created right here. That's your costophrenic angle. It's called your costophrenic angle. Costophrenic angle. You should also be able to pick out the trachea. On this particular chest X-ray, I'll put a line in the middle of the trachea. You can see the trachea here, and it almost has a sigmoid shape to it, an S shape to it. And you need to be able to pick out the bifurcation of the trachea into your right main stem bronchus and your left main stem bronchus. That area of the bifurcation is your carina. It's going to be important to be able to find the carina because that's going to be where you're looking at tips of endotracheal tubes or tracheostomy tubes or NG and OG tubes for that matter. Because if you're seeing an NG tube or OG tube terminate at the level of the carina, it's possible that it got slipped in through the trachea and that's in there. I know that's possible because I went to suction a patient one day and got a lot of tan fluid out of their lungs, and it looked just like tube feed. And come to find out, when the OG tube was put down, it had slipped past the cuff, and they had already turned on tube feed. So this patient's lungs was being filled up with tube feed. So we definitely want to make sure we're assessing those radiopaque lines when we look at our chest X-ray. Over on the patient's left-hand side, you see some pretty well aerated lung fields over here. But you'll notice that there's a difference in contrast when you're looking at the patient's left versus the patient's right. Over here, there's an increase in opacity on the right side. So this is a patient that's got a lot of atelectasis. This patient may very well have a right-sided pneumonia throughout their lungs. Now, these are images that I acquired off the internet, so I don't have a patient history per se to go along with them. Just going over what I can share with you based on things we should be able to see as a respiratory therapist when we're looking at our chest X-ray. Again, you want to be able to see the entire chest on the film. It's kind of blotted out here, but there should be down here radiolucent bubble. That would be your gastric bubble. You'd see that over the area of the stomach. And this trachea, your trachea really should be midline. So you should see this trachea come down and have the bifurcation pretty much like this, as opposed to where we're seeing. So what I've drawn over here is where it should be. And then what we're seeing over here is that. So remember, from going over areas where you go through like inspection, palpation, percussion, and auscultation, you've got pathology that will pull the trachea to the affected side, or you've got pathology that will push the trachea away from the affected side. So if we can, and if you interchange affected side with pathology or disease, you've got things that will pull the trachea to the disease or push the trachea away from the disease. In this particular instance, what's happened is we're seeing a mediastinal shift and a tracheal shift toward the patient's right side. So you've got an increase in atelectasis and consolidation, potentially a pneumonia, on the right side for this particular patient. And that has created the pulling effect. So that has pulled the trachea toward the affected side. And we'll look at some stuff here in a little while where we talk about things that can push it away from the affected side. But pretty much atelectasis, consolidation, pneumonias, or anything of that nature are going to pull the trachea toward the affected side. So you've got a nice sharp costophrenic angle over here. The costophrenic angle is pretty well not able to be seen, or it's pretty well blunted over here because of the atelectasis. You don't have that nice sharp radiolucent appearance as we go through here. The area in which the airways and blood vessels enter into the lungs is going to be your hilar region, or the area of the hilum is what you might see. So your hilar region is going to be where your airways and blood vessels enter into the lungs. So on this particular chest x-ray, make sure that you can, the patient oriented appropriately. You look to see if they're clavicles. You also want to be careful about and you can see that this patient's got their arms kind of held out to the side a little bit. You can see where the head of the humerus is and how their arm would be positioned. Having their arms positioned as such helps to move the scapula in the back area, because you're going to see some rib or you can see some scapula shadow on there that could make you inadvertently think there might be a pneumothorax or something to that effect. Also, I want to make mention, be careful when you are counting your ribs, because I've had several people that I've taught in the past go through and tell me how many ribs there are on one side and they count 24. You got to be careful not to count the same rib twice. So it might be beneficial to kind of count out here where you can see this curvature, each of those ribs as you go down anterior or posteriorly, depending upon the film that you're looking at. So you've got an anterior posterior film that is done more so on the portable side of things, because not every patient in the hospital can be delivered to the radiology department or what have you for a chest x-ray. So some of these things have to be done portable. The AP portable film, because the organs lie a little bit closer to the x-ray source, your heart and stuff may be magnified a little bit in that. So when we're looking at overall quality of films, the posterior anterior film, or the PA film, is actually the film of choice. But with that in mind, not everyone in the hospital can go down to the radiology department and have that done. So those are some things that we'll look at and think about moving forward. But we'll move on to the next chest x-ray. With this chest x-ray, hopefully you can see you've got the tracheal deviation, as well as the atelectasis, increase in radiopacity on the right side, or radiopacness on the right side. And hopefully you can see those changes that are made there. Go ahead and clear that. We'll move on to the next slide. All right, so one thing I want to point out here that we talked about before, we can see the entire, it's a decent looking chest x-ray. We can see the entire chest in this particular film. We can see the spinous process throughout the cervical vertebrae. You can see the rib shadow and stuff to that effect. So you can count the ribs all the way down. You see that the clavicles are pretty well oriented. You see there's a tag over here to let us know that we've got the right side that we're looking at this particular film, you can see nice dome-shaped hemidiaphragms. Here's the gastric bubble that I had mentioned that you should be able to see a little bit earlier. So there's a gastric bubble that you find over the stomach. You come up here, you see this transition in color, if you will. You go from white to a more grayish, if you will, a little more radiolucent. So this is the outline of the trachea, and you can follow that all the way down until you can actually make out your bifurcation. So the bifurcation of your groin is here. You've got good lung markings that extend all the way out to the chest wall and the lung periphery. A good sharp costophrenic angle found on both sides. So for the most part, this is a really good looking chest X-ray, with the exception of your heart. If you note the base of your heart sits back here, and the apex of your heart should be more so in this direction. So if you're looking at the heart should be oriented as such so that the apex points towards the patient's left, and the base is oriented more on the patient's right hand side. So ultimately the heart should kind of be looking that direction. But as you can see, let me pull out the eraser. Take care of those items. We'll go back. So now you can see that this heart kind of points the opposite direction. So this, aside from what else would look like a relatively normal chest X-ray, we have the hilar region and stuff here that can be seen. We've also got the aortic arch that can be seen coming up off of the heart in that area. This particular patient has what would be referred to as dextrocardia. That's where you get malrotation, or where the heart's turning the opposite side. So, typically you should see the apex of the heart pointing down toward the lower left portion of the patient, but this one happens to be pointing the opposite direction. Move on to the next one. All right, so in this particular film, we can see a couple of things that we've not seen before. We'll look at those. So we can see that we've got our little tag over here to let us know this is the right side. There's minimal rotation. The clavicles look to be pretty straight across. It would be advantageous if we could see the entire chest on this film. However, we can with what we've got. So it's hard to look definitely at the entire base of the lungs, what have you. But some important things can still be picked out from this. So you can see that you've got an increase in haziness, some infiltrates and so forth throughout. So although the lung tissue is aerated, it could be aerated a little bit better. We're going to also see the trachea, so I'll outline the trachea again. There's your carina. There's the bifurcation. So the trachea is here. Also notice this distinct radiopaque line, and I am going to do it directly on top of it. This radiopaque line that we see. That radiopaque line, all of your artificial airways and such are going to have a radiopaque line on them, so you can identify where they terminate at. Because you want the tip of your endotracheal tube to terminate 3 to 5 centimeters above the level of the groin. Some places utilize 2 to 4, but for MDRC purposes, you want to utilize 3 to 5 centimeters above the level of the groin. So if this were a true digital film, I would do, or this is a true digital film, but if I had the digital software associated with it, I could pull out a measuring apparatus and measure the distance from the tip of that tube to the tip of the carina, or the level of the groin, and then find that I'm would be within that. See if I'm within the 3 to 5 centimeter window. It's possible the practitioner might decide to advance this tube by about a centimeter to get the tip of it a little bit deeper than the area of the clavicle or what have you. But that would be dependent upon your practitioner and where you and what that true measurement would show when you go through the unit. So knowing that it's in the tracheal tube, you can see this item right here. I'll circle it. You've got on the tip of this in the tracheal tube, toward the tip of it, there's a cuff that gets inflated with air so to seal off the trachea. So there's a cuff on the tip of that intratracheal, and in order to get air into that, you've got to have a pilot tube that goes to your pilot burner, and you can see these little circles right here. The little circles are spring-loaded valve inside of that where you would actually stick the syringe in here and either inflate or deflate your cuff. So this is going to be what you would use if you get ready to move to extubating this patient forward. You can also see the ECG lead wires that are on this particular film, or the electrode tab, excuse me, and then the lead wires you see following up here. You can still see the aortic arch, the aortic knob. You make out where the pulmonary artery would move up as well. It's hard to determine the costophrenic angles because you're not seeing low enough on this particular film. But another item that we did say we could see the spinous processes pretty well on this one. But another thing to notice, you've got this item that enters the neck come down here. So likely this is the central line where you measure like your CVP, RRT, and so forth down there. You might fluid medication administration. The nurses will probably not push much down the central line as respiratory therapy. We'll go ahead and clear that and move on to the next set of chest x-rays. All right, so this is pretty cool here. If we look at this one, again, looking at the tag, we've got our left side, so it's oriented. Clavicles are pretty well, the clavicles are pretty well oriented. We see we've got our gastric bubble down here. We've got our costophrenic angle. We've got a decent costophrenic angle over here. You can see that your lung vascular marking, and you can see this little twist right here. That is your aortic arch, or some, you might also in some textbooks be referred to as your aortic knob. And I told you a while ago, if the arm not moved out, the scapula's not moved that way, you might see a distinct line based upon the scapula. So I'm going to kind of trace this line right here that you might see. That is the shadow from the scapula. So what I've outlined there is your scapula. You can see the spinous process throughout, so that's good. One thing that's a little bit different, so you notice these little vascular markings extend all the way to the chest wall. You'll notice that the vascular markings over here extend and then they stop. And there's a distinct line that you can see pretty much right here. And there's also a little bit of separation in a line here where you've got your scapular line. There's also a little bit of a line where you can see where that's actually the line of the lung. That tends to go up here. So you've got an increase in radiolucency over here. On the patient's right side. So this patient actually has a right-sided pneumothorax. Now, keep in mind the pneumothorax, we talked, the very first slide we started with talked about pathology that would pull the trachea toward the affected side. If you had free air that continued to collect in this pleural space, it would begin to encroach and it could even become under tension. And when it becomes under tension, then it would exert pressure away from the pathology or away from the affected side. And you would see a tracheal shift away from the affected side and potentially a mediastinal shift away from the affected side or away from the pathology. So you've got an increase in radiolucency over here, absence of vascular markings. So if you're listening to this patient via auscultation, you're probably going to have diminished breath sounds on the right side. Not quite absent because you've still got aerated lung tissue. So you have diminished breath sounds on the right side. If you were to assess this patient upon inspection, you may see unilateral chest movement, which you're getting better chest rise on the left side than the right side. And if you go through and break out the old school percussion techniques, you should see your normal resonant tones when you percuss throughout the lung fields over here. Depending upon the onset of atelectasis down toward the basis, those might go from resonant to kind of a dull type tone over it. But over here, you should have hyper-resonant tones when you perform your percussion technique over these fields because you do have a pneumothorax there and it's an air-filled space. Therefore, you get a hyper-resonant or almost a tympanic type sound, if you will, when you percuss over that area. And if you inspect this particular chest x-ray a little bit more closely, you can see why there's a pneumothorax on this particular side. Because if you look here, there's a break in that rib, there's a break in that rib, a break in that rib, potentially a break in this rib. So these are likely punctured the lung and cause that free air to escape into the floor space. So if we look over here, if we had double breaks on adjacent ribs, then you would likely see, you've read about it in books about the paradoxical movement of the chest or paradoxical chest movement. That would be due to your double breaks in the adjacent ribs. But, so far, all I'm able to see is some individual breaks that are pictured over here. So let me clear this and we'll move on to the next one. Looking at the CT, so CTs are pretty cool to get the opportunity while you're in clinical to go about and see a CT be done. One cool thing about a CT is that, and I'm terrible at drawing, so you bear with me, but if you're looking at a patient, and I'm going to draw a patient, stick figure patient lying in supine position. So you got a stick figure patient lying in supine position, supine meaning they're facing up, so they look up. Then your orientation basically is going to be standing at their feet, viewing them from the feet to the head. So if you look at this CT, this should be the patient's left lung, the patient's right lung. This is their back. This is their back. You see the spinous process there. You've got the sternum there. Sternum is here. Relatively decent looking lung fields on both of these. If you were to assess, so basically what happens with the CT is you look at these X-ray views. So when you look at a chest X-ray, it's, it kind of looks at just the whole thing rather, but if you see something that looks suspicious on a chest X-ray, they might decide to order a CT scan, and the CT scan, basically what it does is it takes that patient and slices their body up via images. So it slices their body up via images. So you're able to look at this particular slice of this particular portion of the chest and see what's going on. And you can actually move back and forth if you will. So you can also look at a head CT like that to a chest CT. So we'll be able to look at that moving forward. One thing to note over here, if we're looking at the forces that might oppose ventilation or what have you, look at overall chest wall compliance, you can see based on this CT that this patient has significantly less adipose tissue in their chest wall than this patient does. You've got a lot more radial thickness over here, so a lot more. So if you assume that both of these patients have relatively healthy lungs, you probably have a little bit better compliance. And compliance is the ability of the lung to receive volume. So you've got a little bit better compliance over here than you might over here, simply because the weight of the thorax is going to press down and ultimately kind of decrease lung compliance. Although for this patient, this may be normal for them. If you're looking at straight up measurements of lung compliance and so forth, this chest wall is going to push in on that chest, which would be a force opposing ventilation. So let's go ahead and clear that and move on to the next one. This is not the best film to look at, but you can see that you've got, you can still make out your corona. It's here, the trachea bifurcates, the right left brainstem box. There's slight rotation because this clavicle is a bit higher than the other. And the image is somewhat distorted where it was blown up for the purposes of presentation, but you've got some infiltrates and so forth that exist on both sides as you move forward there. In this particular film, you'll see, if you work in respiratory therapy long enough, you'll see some aspects. So you can see that this patient's life has got scoliosis. You can also see how it could become difficult when we look at obstructive versus restrictive disorders. Portions of the lung based upon anatomical configuration, how difficult that might be for your patient to breathe, or why it might make them more susceptible to atelectasis and consolidation on one side of the chest versus the other. And then we will finish up with this particular film looking at the what should be a normal chest X-ray to be. So some things that we want to make sure that we can pick out on a chest x-ray. You want to make sure that you can see the clavicle. So your clavicle, you know, I'll put a little line here in the right clavicle by that. Spinous processes throughout cervical and thoracic vertebrae. You can see that. This is the apex of your heart. This back here would be more of your base of your heart. Where the airways enter into the lung and your blood vessels, that is your hilum or hilar region. You should be able to pick out the trachea. The trachea is this item right here, so you put trachea here. You should be able to make out the carina. The carina is going to be a little triangular item that gets made at the bifurcation of the left and the right main stem bronchus from the trachea. So this is the carina. This dome-shaped object right here, on this particular case, would be your right hemidiaphragm. We talked about the gastric air bubble. Where the ribs meet the diaphragm. Change colors because that blue is getting let's see. And that becomes your, or not become, it is your costophrenic angle. So we make sure we can pick up the clavicle, see the scapula. So the scapular kind of moved out of this. So you've got the scapula here also. This item that comes up and over, you have to kind of see it there, but your aortic arch, or it can be referred to as the aortic knob, is seen there. So again, terms radiolucent, radiopaque. Radiopaque shows up various shades of gray or white, and radiolucent shows up dark. And so this is a general overview of some basic chest x-ray stuff that we can look at as respiratory, or get you started if you're in respiratory therapy school, to get started on being able to start making sense of what it is that you're looking at. I do recommend, if you're working in the intensive care unit, ICUs, to make sure that you are looking at your chest x-rays on a daily basis of those individuals, especially those that have an artificial airway, because you want to make sure that the artificial airway is in good position, and also make sure there's not been a significant change as far as radiographic images are concerned based upon the care that you got. And then we'll also, you know, finish it up on 12 on each side. You got ribs. So thank you for your time and attention. Have a great day.